It's a pleasure to introduce a true leader in the field of pediatric sleep medicine, Dr. Judith Owens. Dr. Owens serves as a professor of neurology at Harvard Medical School and is a key member of the Center for Pediatric Sleep Disorders at Boston's Children's Hospital. Over the course of her career, she has helped shape how we understand, evaluate, and manage sleep in children, translating complex issues and science into practical, patient-centered care that has influenced both clinical practice and public health. Her work spans everything from behavioral sleep disorders to a broader neurodevelopmental and societal impact of sleep, making her voice both authoritative and deeply relevant in today's landscape. We're fortunate to have her shape her insight and expertise on pediatric sleep medicine. Please join me in welcoming Dr. Judith Owens.
Hello, my name is Judith Owens, and I am privileged to present to you just a slice of the universe of pediatric sleep medicine. And what we're going to focus on today is, first of all, a very common issue, and that is the presentation and management of childhood insomnia. And we'll touch on behavioral interventions and in particular on melatonin use. Secondly, I'm going to list the key features and basic treatment strategies for restless leg syndrome and periodic limb movement disorder in children, and a new entity called restless sleep disorder. And then finally, I'll talk about the key features that characterize arousal disorders, i.e. parasomnias in children. So first up, the clinical presentation and management of pediatric insomnia. Now, in the International Classification of Sleep Disorders, the recent revision, chronic insomnia disorder, and I've highlighted what is particularly pertinent to the pediatric population, is that the patient's parents or caregiver observes one or more of the following: difficulty initiating sleep, maintaining sleep, waking up earlier than desired, and here's where it is pertinent to children: resistance going to bed on an appropriate schedule, and difficulty sleeping without a parent or a caregiver present. And these complaints need to be occurring at least 3 times a week for at least 3 months. Now, in terms of the repercussions of pediatric insomnia, again, we have the patient, or much more likely, the parents or caregivers observing one of the following issues. And that includes issues with attention and concentration, impaired social, family, or academic performance, mood disturbances, daytime sleepiness, behavioral problems, which most often are actually a manifestation of daytime sleepiness, especially in young children, and that includes hyperactivity, impulsivity, aggression, acting out behaviors. I also want to talk a little bit about some older definitions back in the second version of the ICSD of what was then called behavioral insomnia of childhood, because I think that these clinical definitions are still very useful in terms of teasing out exactly what's going on when particularly a younger child presents with insomnia. So the first type here is what's called the sleep onset association type. And as the name implies, sleep onset associations are often highly problematic or demanding, and typically involve having a caregiver present while the child is falling asleep. And so if the parent is, or the caregiver is not there at bedtime, sleep onset is typically significantly delayed, or sometimes sleep is disrupted because nighttime awakenings also require caregiver intervention for the child to return to sleep. So the problem here is not only that the child has difficulty falling asleep independently, but they have difficulty falling back to sleep after normal night awakenings, and again, require caregiver intervention. The second type of behavioral insomnia of childhood is what's called the limit setting subtype. And this is generally a problem with difficulty initiating and or maintaining sleep. And it's characterized by stalling behavior, bedtime refusal at an appropriate time, or refusing to return to bed following a nighttime awakening. And usually this occurs in the context of a caregiver who already demonstrates insufficient or inappropriate limit setting during the day, and that also translates to difficulty setting limits about appropriate sleeping behavior at night. The third type, which isn't mentioned in the ICSD classifications, but I think is very important to be aware of, is what is called too much time in bed. So, for example, if a child's normal sleep need is 10 hours, but they are expected to be in bed for 12 hours, what happens? Well, they might take 2 hours to fall asleep and then sleep through the night for the rest of their 10 hours. They might fall asleep easily, sleep for 6 hours, have a long period of awakening during the night, and then resume sleep to make up their needed 10 hours. Or similarly, they may have a series of multiple sleep interruptions during the night, but then they're still getting their expected complement of 10 hours. And this is important to recognize because really the solution is to fit the hours in bed with the sleep needs. And so it's a relatively straightforward management strategy. So now I'm going to talk more about behavioral interventions for insomnia in children. So the first has a terrible name, which we're kind of stuck with, called extinction. And that is a psychological term that means that you're trying to eliminate caregiver attention as a reinforcer for undesired behavior, like protest behavior or crying. Now, what's called unmodified extinction, or sometimes the cry it out or the cold turkey approach, is one in which parents put the child to bed at their designated bedtime and then ignore any protest behaviors, such as tantrums, until a preset time the next morning. Now, unfortunately, although in research studies this works very well, it's often poorly tolerated by parents because it involves a period of time in which the child is quite distressed. So as a result, variations on extinction, typically called graduated extinction, or in the lay parlance, sleep training, the checking method, controlled crying, the Herber method, is a variety of techniques in which parents are typically instructed to ignore the bedtime crying, protests, tantrums for specified periods of time. And I'll talk a little bit more about what that looks like. But the idea here is this involves gradual shaping of appropriate behaviors and then fading over time of the interventions. So something called bedtime fading relates again to that issue of too much time in bed. So this involves temporarily delaying the bedtime to match what the child's natural fall asleep time is and allow the child to fall asleep quickly. And then bedtime is gradually moved earlier by successive increments. For example, 15 minutes every few days over successive nights, that's the fading piece, until a pre-established bedtime goal is achieved. And oftentimes that's a compromise between the original bedtime and the child's natural fall asleep time. Now, these don't always go as smoothly as one would like, so there are certain issues to pay attention to. First of all, you want to ensure that the child is ready to fall asleep. And when we talk about sleep training, we encourage parents to put the child to bed drowsy but awake so that they don't remember the last thing before they fall asleep as parental presence, which as a sleep onset association. Now, if you do the checking method, if parents come back and check the child periodically during the night, that time interval can be either fixed or variable, and that really depends on the child's temperament, for example, and also the parent's tolerance for crying. We also encourage them to avoid reinforcement during checks. This isn't playtime. It's parents coming in, having a script. You're here, I'm here, you're safe. It's time to go to sleep. I'll come back and check on you in a few minutes. Now, for younger children, gates or some sort of physical barrier so they can't actually leave the room allows the parent to come to the door. It's a physical but not a visual barrier. So the parent can talk to the child, reassure the child, but the child is unable to come out of the room. Now, this is very important. There's something called the extinction burst, which means that crying and protest behavior often briefly intensifies in the second or third night after these behavioral interventions are instituted. And if you don't warn parents about this, they will assume that things are getting worse instead of better, when in fact that goes away after that increase in protest behavior at the second or third night. And overall, either intermittent or non-consistent use of any of these behavioral plans is the most common reason for treatment failure. Now, one of the things that parents often resort to, and some of this is unfortunate, is the use of melatonin, including in young children. And I want to talk a little bit about what some of the caveats here are. So in the United States, melatonin is considered a dietary supplement, which means it has little oversight from the FDA. And the FDA considers these supplements as, quote, safe until proven otherwise. Clinical trials aren't required. They are required in theory to meet label content, plus or minus 10% of the actual content and the label content. I'll talk about that a little bit more in a bit. And these preparations for the pediatric population of melatonin are now being heavily marketed in the United States. So that's important to be aware of. So what does that mean? What's the extent of melatonin use? So a recent study of caregivers found that among children 5 to 9 years old, almost 1 in 5 had been given melatonin in the previous 30 days. And little older kids, elementary school students, preteens, had been using melatonin for median lengths of 18 and 21 months, respectively. And even nearly 6% of preschoolers, 1 to 4 years of age, had taken melatonin in the previous month and had been using melatonin for a median length of a year. So not only is this a common approach to treating insomnia, even in young children, but it is often continued for prolonged periods of time. And when you compare that to not so long ago in 2017 and 18, only 1% of caregivers in the US reported giving their child melatonin. So there's really been an explosion in this over the last few years. Now, I call this what you see me, not be what you get. You remember that these supplements are supposed to be in actual content within 10% of the label. Well, a recent study by the FDA analyzed a random sample of 110 pediatric melatonin supplements with chromatography, including gummies, and found that, for example, overall, the content ranged from 0 to 667% of the label. And gummies, liquid, other edibles, other formulations of pediatric marketed melatonin had similar wide variability. The other issue is there degradation of the melatonin products so that the manufacturers overreach the content at the beginning when it's initially put on the shelf, but this study did not find any significant degradation over 12 months. And furthermore, products that were essentially for adults were also marketed to children on the product website. Many of them were co-formulated with other ingredients. The good news, I guess, is that the majority of those were in childproof packaging and included a recommendation to consult a healthcare provider before giving melatonin. This has also resulted in some significant safety concerns. For example, poison control center calls increased by 530% between 2012 and 21 in terms of melatonin accidental ingestions. Similarly, in terms of emergency department visits, melatonin ingestions increased by over 400%. And another study which we did is less than 50% of caregivers of children given melatonin between the ages of 0 and 36 months had consulted a provider before giving melatonin. And oftentimes these are for unsupported medications. And by the way, melatonin is not recommended for children under 2. We also did a study looking at TikTok videos that contained information about melatonin, and 40% of those had misinformation with unsubstantiated indications and delivery systems like diffusers and lotions containing melatonin that are unsubstantiated. And so overall, this contributes to issues with caregiver and healthcare provider not being confident about using melatonin and both overuse, underuse, and also misuse of melatonin. So recent recommendations that we've published in the journal Sleep Medicine particularly supports melatonin for special needs populations. That is the most robust evidence we have. There's really very limited data that supports use in healthy, typically developing children, but it can be useful with the caveat that a thorough sleep evaluation identifies insomnia and rules out other potential causes of the presenting symptoms, and it is combined with behavioral interventions and healthy sleep practices. It should be used only under the care of a medical professional, as I mentioned, not in children under age 2. Immediate release melatonin is only for sleep onset melatonin, but there are forms of melatonin that are available currently not in the United States that appear to be controlled release and have been used successfully in clinical trials for sleep maintenance insomnia as well. And if you don't remember anything else about melatonin, it's really important to try to only recommend what's called pharmaceutical grade or USP verified mark melatonin, because that is most likely to have the actual content meet the label. And just be aware that now there are a number of over-the-counter medications for children that contain melatonin, although they're not necessarily advertised as such, but those can include cough syrups and relaxation aids. So now I'm going to switch gears a bit and talk about pediatric restless leg, periodic limb movements, and restless sleep disorders. And I want to preface this by saying that overall our knowledge about risk factors, epidemiology, genetics, and particularly natural history in these disorders in the pediatric population is really relatively sparse compared to what we know in adults. Now, in terms of restless legs, these symptoms can start as early as 6 to 12 months of age. Pedaling the legs, kicking, slapping the legs, accompanied by evidence of distress. In children, the subjective symptoms of a need to move and the uncomfortable sensations occur primarily in the legs, but also appears that arm sensation are relatively common in children, although rarely the presenting complaint. A significant percentage, and this is important, of children also report having daytime symptoms when inactive, like sitting at a desk for a prolonged period in school. Very frequently, parents of children with RLS don't come in and say, I think my child has restless legs, but they talk about bedtime resistance and difficulty falling asleep because of those symptoms. We also see impairments in mood, daily activities, academic work, for example, in children with restless legs, and neurobehavioral symptoms such as inattention and hyperactivity may be the presenting complaints. And in one study, 64% of pediatric patients with RLS had one or more comorbid psychiatric disorders. Now, whether that's cause, effect, bidirectional, we're not exactly sure, but very common to see mood disturbances, anxiety disorder, and behavioral disturbances. Now, in terms of the epidemiology, there was a large study that was done a number of years ago, the REST study in the US and the UK, and found overall a prevalence of about 2% of what matched the definition of definite RLS. And that represents about 980,000 school-age children. So it's not an uncommon disorder. About 1/4 to a half of these children and adolescents have moderate to severe symptoms, particularly in adolescence. Another smaller study of adolescents found prevalence of about 8%. Now, in terms of periodic limb movement disorder, that's much more difficult to establish the prevalence because currently a definitive diagnosis requires polysomnographic corroboration. But it's estimated in one study, for example, in sleep clinic referral populations to be about anywhere between 5 and around 25%. So in terms of etiology, there clearly is a genetic component. In that rest study I mentioned, 70 to 80% of children with definite RLS had at least one biological parent with restless legs. Low ferritin levels. So low iron is a very important cause driver for restless legs and periodic limb movements in children, as it is in adults. So it's defined in children as a ferritin level of less than 50, and that has been found in 70 to 75% of children with restless leg symptoms. Now, several things to remember is ferritin is an acute phase reactant, and it may be elevated if the child has a concomitant illness, like an upper respiratory tract infection. Consider, in addition to measuring ferritin levels, iron, plasma iron, transferrin, total iron binding capacity levels as well. And remember that levels are impacted by consumption of iron-rich foods. And so we recommend that the ferritin level be done in the morning, and that the child not be on any iron supplements or eat any high iron containing foods for at least the day before the testing. Now, children with ADHD who are at high risk for restless legs may also be more likely to have low ferritin levels and RLS. And there's also some data which suggests that low vitamin D levels are also linked to the etiology of restless leg. Now, it's a challenging diagnosis in that we do ask that the child is required to describe the restless leg symptoms in their own words. But children, and I'll share this in just a minute, have some fairly colorful descriptions of their symptoms. And so considering language and cognitive development in terms of how you assess the presenting complaints in the words of the child. Now, in terms of periodic limb movements, we sometimes rely on parental reports of leg movements during sleep, but really that clinical complaint lacks adequate sensitivity or specificity. And just to remember that the diagnosis of periodic limb movement disorder requires some sequelae from the periodic limb movements, and also the cutoff is different in pediatrics, i.e. more than 5 periodic limb movements an hour on polysomnography compared to more than 15 per hour in adults. Now, some of the words, this is a fun study that we did a number of years ago, where we asked children to describe their symptoms. And understandably, they'd say things like, well, I need to move, it hurts, I can't get comfortable. but pins and needles, wiggly, itchy, restless, fizzing, bubbles. One child described it as soda bubbling in my veins. And we also did a study where we asked children to draw their restless leg symptoms. And that is sometimes a really interesting way to get at the self-report issues that we struggle with sometimes with children. The general treatment approach is what's called AIMS. So you want to avoid any drugs that might exacerbate restless legs in children. Those tend to be things like antihistamines, but in certain children they can be antidepressants like tricyclic antidepressants and SSRIs. Caffeine, nicotine, and alcohol in adolescents could possibly be an issue as well. Iron supplementation, I'll talk about in just a minute. Muscles, so counterstimulation like rubbing the legs, massage, applying heat or cold. Many families describe that as being helpful in alleviating the symptoms. And there are a few studies which suggest that muscle relaxation and biofeedback may also be helpful. And finally, the S for sleep, having a regular sleep schedule that allows for an adequate amount of sleep, and just generally healthy sleep practices are also recommended. Now, restless sleep disorder is a relatively new entity, and a complaint of restless sleep, which is extraordinarily common in children, is the core diagnostic feature. And like many other diagnostic criteria, has to be present at least 3 times a week for at least 3 months. Now, typically, this restless sleep is reported by a parent or caregiver or potentially a bed partner, like a sibling sometimes, but occasionally is reported by the patient themselves based on what others have observed or the condition of their bed when awakening. And as with many issues, the symptom is restless sleep, but in order to be considered a disorder, there must be sequelae involved. So many children are restless. How do we differentiate this disorder? So these visible body movements involve large muscle groups of the whole body, all 4 limbs, arms, legs, or head during sleep, accompanied by frequent repositioning, bedclothes all over the place. It's not unusual to see children actually falling out of bed. And the strict diagnostic criteria for RSD involves video polysomnography and requires total body movements of at least 5 per hour. But from a practical standpoint, we're not often going to really consider doing a sleep study on children like this, and we rely more on the severity of the restlessness and the frequency of it. We also expect to see a significant impairment in function, similar to what you would see with restless leg syndrome. But again, these symptoms are not relegated to just the legs or the arms, and it's movement, not accompanied by dysthesias or uncomfortable feelings. And RSD is also associated with low ferritin levels and responds symptomatically to iron therapy. Now, in terms of oral treatment for restless legs and periodic limb movements in children, we typically use ferrous fumarate or sulfate, either a tablet or liquid, 3 to 6 milligrams per kilogram of elemental iron per day, which can be given once or as a split dose for about 3 months with vitamin C on an empty stomach to increase absorption, avoiding calcium-containing foods, which slow absorption, and sometimes can also be effective at every other day dosing. In some cases in which there's maybe some resistance to taking the medication daily. The absorption, oral absorption in the GI tract actually seems to be higher at lower baseline levels, kind of the opposite of what it says on the slide. And the goal is ferritin above 50, but there's no necessarily not consensus about this, and I couldn't really find a lot of references one way or the other. But clinically, typically in symptomatic children, we aim for a level of 75 to 100. Now, IV iron therapy has become an increasingly common potential treatment, but consider it in the case of moderate to severe disease. If the serum ferritin level is clearly less than 100 and the child is still symptomatic, with a transferrin saturation to avoid iron overload of less than 45, it can be used in a situation where oral iron has been a treatment failure, intolerance, or lack of efficacy. If the child has a condition that blocks oral iron absorption or makes response unlikely, and if oral iron is contraindicated, or finally, if the clinical need is for a more rapid response than what we see with the 3-month interval with oral iron. Typically used ferric or carboxymaltose or low molecular weight dextran. There's always been concern about possible anaphylactic response to IV iron and requiring treatment with diphenhydramine, for example, although that really hasn't panned out in clinical trials. And then to evaluate clinically 6 to 12 weeks after the iron IV therapy, and then adjust any other treatments as indicated. So finally, I'm going to end up with non-REM disorders of arousals in one of my favorite movies, Monsters, Inc. So the ICSD-3 TR defines disorders of arousal as recurrent episodes of incomplete awakening, including inappropriate or absent responsiveness to the efforts of others, particularly caregivers, to intervene or redirect the behavior, limited or no associated cognitive or dream imagery, importantly, partial or complete amnesia for the episode, and the disturbance is not better explained by other potential causes. So these disorders of arousal, which include confusional arousals, sleepwalking, and sleep terrors, combine clinical features of the sleep state. So these children are very difficult to awaken. They have a high arousal threshold, and they don't respond to external stimuli like caregivers trying to comfort them. There's also some features of the awake state. They can walk around. They can vocalize, particularly with sleep terrors. Typically, these behaviors emerge out of slow wave sleep, but not exclusively, some out of stage 2 sleep. And because they're typically occurring in slow wave sleep, they usually are observed within the first 3 hours of sleep, which is where the slow wave sleep is concentrated, particularly in children, and they're rare during naps. They generally occur about 1 to 3 times per month on average, but that varies widely. They can last from a few minutes to up to 45 minutes. They're characterized by confusion, disorientation, and they can be induced in susceptible individuals. There's a very strong familial component, and overall, there is a decline in these episodes with increasing age, partly because the percentage or amount of slow wave sleep gradually decreases over childhood. So they're exacerbated by factors that increase slow wave sleep, like sleep deprivation, for example. You get rebound increase in deep sleep, or sleep fragmentation. Sleep schedule changes sometimes instigate or exacerbate or trigger these episodes. They're also increased by alcohol, caffeine, and medications, particularly sleepwalking, such as benzodiazepine receptor agonists, antidepressants, and their strongest evidence of a pharmacologic trigger is zolpidem and sodium oxybate used for narcolepsy. We also can see exacerbations or flares in these episodes with stress, environmental changes. Some children only have them in sleeping in strange places outside of their home, for example, or illness, particularly febrile illness, and they can be exacerbated, again, related to sleep fragmentation by sleep disordered breathing or restless legs and periodic limb movements. So sleep terrors occur in about 1 to 6% of children less than 7 years. So they're not that common, but they're very dramatic. So the prevalence is in preschool children. They usually disappear by adolescence, and the frequency is usually highest when the child first presents with these episodes. And particularly if they have a younger age onset of symptoms, the prevalence is oftentimes quite high initially. They're characterized by drama, extreme terror, fright. The child seems very frightened. Their eyes are usually or often open. They have an intense autonomic response with dilated pupils, flushing, sweating, tachycardia, tachypnea, and a very agitated appearance with screaming often, and they're inconsolable. Occasionally but rarely, there's something called parasomnia, choking as well, which can occur in children. Sleepwalking is reported in a higher percentage of children, again in preschool to early school age, and the peak prevalence is at 10 years. Again, you see this genetic component with 47% having one parent with a history of sleepwalking, 61% with both. It's characterized by confused, appearing dazed, and agitated behavior. You can see complex and coordinated movements. Children can get dressed, unlock a door, but also bizarre behaviors like urinating in a wastebasket, for example. You may see automatic movements, impaired judgment. So there are definitely safety concerns. Children can climb out of windows, leave the house, can have self-injury with cuts or bruises, can be relatively common. So this is, of the three entities, this is the one that you need to be most aware of the safety issues. Then confusional arousals, which are kind of at the other end of the spectrum of sleep terrors, these are very common in young children and rarely persist into adulthood. So this is an entity that occurs in infants, toddlers, young children, and maybe the first initial presentation of an arousal disorder preceding sleep terrors and sleepwalking. So the sort of chronological progression here is confusional arousals first in the younger age group, followed by sleep terrors, followed by sleepwalking. And not all children by any means have all three, but that is kind of the typical age progression. The infant, young child appears disoriented, unresponsive, no recall if they're verbal. These tend to last a few minutes, but can go on for quite a long period of time. This is potentially the 45-minute version of an arousal disorder. The child typically remains in bed, unlike sleepwalking, and these can be triggered by environmental external stimuli like sudden noises, for example. And they're also reported in the morning when a child is awakened early and can be accompanied by odd behavior. So the typical scenario is a child sits up in bed, looks around, maybe seems a little distressed. You may hear moaning or mumbling, but not the level of agitation you would see with a sleep terror. And then just goes back to sleep, but they're actually asleep during the episode. So management just in general of these are parental reassurance and education that these are normal childhood phenomenon, safety precautions, particularly again with sleepwalking, avoiding triggers or exacerbating factors that result in sleep fragmentation or increased slow wave sleep. So again, sleeping less the night before, resulting in a rebound of slow wave sleep, that's when you oftentimes will see an episode. Stress reduction, relaxation. There's something called scheduled awakenings. So for frequent episodes of either sleep terrors or sleepwalking, we will ask the parent to track when the episode typically occurs, and then to awaken the child kind of proactively about a half an hour or so before the timing of the typical event. And it works about 50% of the time, and then you don't have to resort to other kinds of management strategies. But in general, pharmacotherapy is rarely needed. And you don't want to use them because most of them that are effective for these arousal disorders suppress slow wave sleep. And that's not something you want to do in the developing child. So thank you for your attention. I hope we have a little time for questions or comments, and I appreciate very much your attention, and have a good night's sleep.
Thank you so much, Dr. Owens. That was really a wonderful overview, and I think we do have a few minutes for the Q&A, which we will address right now. Thank you so much.